name is Sarah Goodwin, paediatric dietitian at Hull Royal Infirmary, part of the Hull University Teaching Hospitals. I was nominated as the QI Clinical Champion, and this photo shows our team at the beginning of the project in March. We're a fairly big team with a number of different members to the team, but as you can see on the next slide, right, unfortunately, we've had some team changes during this time period. On a positive change, we've had a new consultant being able to join our team. So that's a real positive to the QI programme. However, unfortunately, we've had one of our nurses leave the team to move to a different post. Our lead nurse is due to retire at the end of the month, and we've had some sickness during this time period and staff shortages. So at some time periods, we've had no nurses in post. One of our dietitians is due to leave at the end of this month. Our data quality officer has already left her post, and we haven't had the replacement join our team just yet. And we've had a change in psychologist as well. So for all we've been a big team, we've been short of numbers at some points in time. The aim of our QI initiative is to reduce the mean HbA1c of our cohort by improving the self-management skills of our children and young people. We have a cohort of approximately 238 patients, and unfortunately, Hull has been a negative outlier for the HbA1c for the past number of years. So this is something as a team we really wanted to focus on and improve on. The objectives is our first thing we wanted to do was to enable all our children and young people to be able to home upload their devices. Once they were able to do this, we wanted to empower them to be able to review data and adjust their insulin doses to be able to self-manage. We also wanted to implement into carbohydrate counting from diagnosis, as this is something that we hadn't been able to do in the past. Who are we connecting with to improve our work? Within our organisation, we're connecting with the entire MDT team. We're having regular meetings to be able to discuss our plans and actions. Outside of the organisation, we're engaging with our parents and patients. We've sent them a flyer stating that we're running this quality improvement project, and it was about uploading and encouraging all our patients to be able to upload their data. We've also been able to purchase the DigiBeat app, so all our patients can use this app as a means of communicating with them. We've also been engaging with the psychologists who work just outside of our organisation, and we've been using the psychologists to advise us as a team on ways how we can engage and empower and encourage our patients. Carbohydrate counting upon diagnosis. This is something that we'll manage to start implementing just before the official start of the QI project at the beginning of February. Previous to this, patients would be seen on the ward by a dietitian, and then they would be discharged home on a fixed dose of insulin, and they would be taught a carbohydrate count approximately 2 weeks later. From February, all patients were taught a carbohydrate count on the ward. This meant that from their first injection of subcutaneous insulin, and everything was carbohydrate counted. So initially this was done by the nurse and staff on the ward. The parents were trained, and then they would go home using their insulin carbohydrate ratios. Since February, we've had 12 patients diagnosed. Unfortunately, only 11 of them have been able to be taught carbohydrate counting whilst on the ward, as one patient came in through adult services and the paediatric team wasn't informed prior until post-discharge, but they were then taught within a timely period following this. In terms of timescale, most patients are seen by the dietitian and taught within 1 to 2 days of being diagnosed, or some patients it's taken slightly longer, and this is predominantly if a patient comes in late Thursday, the dietitians see them twice, so they would see them then on a Friday and then the Monday. And then I'll hand to Sanjay.
Okay. Next slide.
Okay, so I'll just talk about our improvement journey so far. So the other aspect was encouraging patients to upload, and we thought we'll start by identifying how many are not uploading and the reasons behind that. So at the start of our QI project, there were about 33% of patients who were not uploading the devices. And then the COVID came through, and that forced some more patients actually to start uploading because we moved on to virtual consultation. And fortunate for us, then that figure dropped to 24%. And on the right-hand side of the slide, you can see the bar charts, which depicts the reasons for people not uploading. So the number identified were 56 out of the 238. And as you can see, majority of them had technology or computer related issues as the reasons for them not being able to upload. About 15 patients we were either not able to contact, or when we contacted, they asked us to ring another time. And we thought this was the patient cohort which was like non-engaging with the team or with technology. Similarly, I think, five patients or parents, said they didn't have any reason or they did not have time to upload. Four were not on any special devices, and we had problems with the solo pump as a team as well, because uploading that on the platform was difficult for the team itself. Two parents reported language barrier, and we realized as a team we hadn't sent the invite to two of the patients. Next slide, please, Andrea. So what we have improved as a team, we have set aside the ring fence time, as Sarah mentioned, to discuss the QI. The first few meetings were face-to-face, and then the meetings have been held virtually with team members joining from their offices or home, but then some members will sit together in a bigger room. Despite the big changes in the MDT, I'm glad that we have and thanks to Sarah, that we have continued to keep up with the meeting schedules, including the timekeeping and minute taking. Next slide, please. So this is our last slide, and the most important pieces of learning. We as a team have realized that opinion of every team member is important and valuable. So including our data coordinator, who would come up with some very sensible suggestions and could think outside the box as a non-clinician. I think as a team, we should be proactively collecting these data rather than retrospectively. And I think that data does come in handy when we are trying to either push for a case for extra team members or technologies. And it's important to set achievable targets regarding our patient cohort to identify what problems they might be having. And sometimes as a team, we have to learn that it is not just the patients, we have to improve ourselves. We thought that they are not uploading, but then we identified that as a team, we had sent them multiple invites or registered them with multiple email addresses, which was the cause of problem. So thank you for your attention, guys. And we can take some questions now.